Hello, everyone, and thank you for attending this talk. I'm Cory Hale. I'm the Infectious Disease Clinical Pharmacist at Hershey Medical Center. Today, we'll be discussing our research entitled Antimicrobial Stewardship Opportunities using result from a multiplex lower respiratory tract panel as compared to conventional culture. I have no personal disclosures relevant to the content of this presentation other than noting that this was a Curatus-sponsored research protocol. Pneumonia represents a significant burden on the U.S. healthcare system and is associated with high rates of morbidity and mortality. Community-acquired pneumonia is estimated to cause approximately 1.5 million hospitalizations, 100,000 deaths, and nearly $10 billion in healthcare costs each year. In addition to CAP, ventilator-associated pneumonia and hospital-acquired pneumonia are the most common healthcare-associated infections and are often managed with broader spectrum antibiotics to include coverage for multi-drug resistant organisms, including MRSA and Pseudomonas, due to their association with poor outcomes. For these reasons, guidelines advocate for initial broad spectrum therapy, differences in coverage for CAP compared to HAP and VAP, as delays in effective therapy are associated with increased mortality. The same sets of guidelines advocate for de-escalation of antibiotic coverage once the causative pathogen is known. Therefore, the microbiology lab plays a pivotal role in improving outcomes in patients with pneumonia, particularly through collaboration with an antimicrobial stewardship program. The standard diagnostic method for bacterial identification of suspected pneumonia is gram stain and culture. Notably, the turnaround times for respiratory cultures in these diagnostic tests is upwards of 72 hours, are often negative due to poor sensitivity, and clinically important pathogens may be concealed by the growth of multiple organisms in culture. The time that is required to facilitate bacterial growth for identification and susceptibility testing may cause significant delays in clinical decision-making, thereby limiting our ability to both reduce broad-spectrum antibiotic exposure and initiate targeted therapy. Advocated for by national guidelines, molecular rapid diagnostic tests have the potential to increase sensitivity and decrease time to results when compared to traditional culture methods. It is also worth noting that without concomitant antimicrobial stewardship program intervention, rapid diagnostic tests alone have less impact on clinical outcomes. The Curatus Univera lower respiratory tract panel is an FDA-approved molecular panel that detects 19 of the most common bacterial respiratory pathogens and 10 antibiotic resistance markers in under 5 hours. Recent studies have found high levels of correlation between the results of bacterial culture and the Univera, including our own technical assessment, which was presented at the 2020 ASM Microbe poster session. These panels can rapidly identify most common pathogens associated with CAP, HAP, and VAP, and implementation can result in actionable results for clinicians, though more clinical data are needed to establish their role in guiding decision-making. The specifics of this panel are included here for your information. When evaluating a highly sensitive panel like this, the question becomes, what might clinicians do with these results in real time, particularly in such situations where the lab would typically report normal respiratory flora? So clearly, there's a benefit of knowing the presence of important potential pathogens that may be masked by normal flora, like MRSA and Pseudomonas, and the resistance genes, noting that there's other potential mechanisms at play. But what about organisms that are common colonizers, like Stenotrophomonas, that require specific antibiotic coverage? Could this unintentionally lead to antibiotic overuse? And secondarily, are there worse outcomes when we don't cover organisms identified by PCR that were not identified in culture? Therefore, we set out to identify potential antibiotic stewardship opportunities associated that may be anticipated with implementation of the Univera panel. The primary objective was to characterize the potential impact of reporting rapidly with the Univera panel on antibiotic therapy in patients being treated for pneumonia, specifically looking at the escalation and de-escalation moves that would be made by clinicians interpreting these results. Secondarily, we wanted to compare outcomes between patients who yielded equivalent results between Univera and conventional culture and those who yielded discrepant results. This study was conducted at Penn State Health Milton S. Hershey Medical Center, a 628-bed academic medical center and children's hospital located in rural Hershey, Pennsylvania. This was a retrospective chart review study from whom existing specimens were used to assess the technical performance of the LRT panel, and the results were not reported in the electronic medical record. All specimens were cultured using standard of care protocols. Panel results were not reported in the electronic medical record, but were compared to the standard of care result in chart review. We classified these results into 3 categories, as you see here, based on the concordance between the 2 tests. with match plus meaning additional information was made available by the Univera panel compared to culture, match minus when the panel did not detect results that were reported by culture, and match equals when the two results matched on panel organisms. Descriptive statistics were used. Patients were included if they were inpatient, adult, or pediatric patients, had a sputum or tracheal aspirate sample that was tested on the panel, and had conventional culture results reported in the electronic medical record. We excluded cystic fibrosis panels, patients, those with invalid panel results, and those who were not being treated for pneumonia or were discharged or died within 24 hours of the sample. Each patient chart was then reviewed by a stewardship pharmacist to determine potential impact of this reporting on antibiotic therapy with the interpretation based on local practice, eventual definitive treatment that was used. So if Pseudomonas did not grow in the culture and Pseudomonas coverage was continued for the full duration, this was not counted as a potential de-escalation because the Univera would not have changed the clinical decision and other anticipated real-time ASP interventions. These were then classified into subcategories of escalation or de-escalation. Of the 172 cultures review, 92 patients could be included, which included 53 sputum samples and 39 endotracheal or tracheal aspirates, with the primary reason for exclusion being the patient was not treated for pneumonia. Patient characteristics are described here, noting that 42.4% of our patients were pediatrics, 55.4% were in the ICU, so we had a good proportion of critically ill patients, and nearly half of patients had an additional potential indication for antibiotics in the differential other than just pneumonia, most commonly UTI or bacteremia. In terms of the type of pneumonia being treated, as you see on the right side of the slide, a majority were not specifically identified in this chart as CAP, HAP, or BAP. These were under problems like sepsis or acute respiratory failure. Of those that did have a diagnosis in the chart, there was a pretty even split between CAP and HAP and BAP. 45.7% of our patients were classified as match plus, meaning the panel yielded more information than culture. 4.3% were match minus, and 50% were match equals. Without going through the whole list of organisms, I wanted to point out the most common is Stenotrophomonas in 23.9%, followed by Pseudomonas and Staph aureus. 27.2% of patients had no organism detected on the Univera panel, and normal respiratory flora was really common in our culture results, and 80.4% containing that term in some portion of the results, about 2/3 of those as the only result without calling out any organisms. In terms of resistance markers, only 7 were detected in 5 patients. Notably, 2 of the 4 MEC-A results were in cultures that yielded a report of normal respiratory flora, which could be really clinically important and clinically relevant and important to not overlook. For the primary outcome, a change in antibiotic regimen was anticipated in 33.7% of patients reviewed. 12 patients, or 13% overall, would likely have been de-escalated sooner, with over half of those having atypical coverage discontinued, quarter of them with MRSA coverage stopped, and less commonly, all anti-pseudomonal agents stopped. Escalation of therapy would be more common in 23.9% of patients. Interestingly, with the addition of Stenotrophomonas coverage being the most common, noting here that escalation was determined to have likely have occurred, but may not have been clinically necessary for all of our patients. In terms of clinical outcomes, we did take a look at mortality and 30-day readmission between match plus and match equals patients. We did not detect a difference, but we were unlikely to have met any sort of power to detect that meaningful difference. This area deserves much more research. Our study was limited in the fact that it was a retrospective study. We were limited to the available samples we had in the microlab to use, so could not really tailor our inclusion-exclusion. And it was chart review where our assessment favored escalation or not de-escalating based on the clinical decision at that point in time. We did have a high percentage of tracheal aspirate cultures, particularly in our pediatric patients with chronic pulmonary problems. If we look at other studies here that have looked at the same panel, our percent of de-escalation was far lower than the other 2 studies. One was in adult patients with suspected pneumonia and the other adult ICU patients with HAP or VAP. This may be due to our inclusion of a high percentage of pediatric patients and also the fact that our chart review somewhat favored not de-escalating. So I think compared to the other studies, our study represents a worst case scenario of de-escalation without direct antimicrobial stewardship intervention. Escalation opportunities, however, were pretty consistent amongst the studies, around 20%. I think we do need more research and real-time data for de-escalation moves, though, because subjectivity is highly variable. So in conclusion, decreased turnaround time of results provided by the Univera could provide targeted coverage sooner, but should be coupled with an antimicrobial stewardship program to ensure coverage is optimal and necessary. Institutions implementing these panels need to determine a reporting plan and may consider things like selective reporting based on organisms, maybe leaving out Stenotrophomonas, acuity of patients, ICU versus non-ICU, pediatrics versus adults, gram state result, and the number of organisms detected. And more data are really needed with real-time assessment where the clinicians and antibiotic stewards are presented with the rapid results and making interventions. With that, thank you for your time. That concludes my presentation.